Thank you, Sarasota Memorial, for asking me to offer this lecture here. And I can't believe I've been here in Sarasota now, coming on 10 years. I am now officially old, but I don't believe it. I don't believe it at all. And I would have to say, I think we should congratulate Dr. Morsley on that really amazing talk on that cardiac rehab. Let's give him a nice round of applause. I don't know where he went. He's probably eating a steak right now. But I'm going to have to say that cardiac rehab, I would say, it's not part of my lecture, but we have a lot of patients that we do refer into there, and they come back after their sessions really wanting to do a phase 3, really, which there is a phase 3. And the results are pretty amazing. So just to get started on my talk, we've done the valve talks, the TAVR talks here, I think in the last summit, and I think our institution, we've been, 4 years now doing TAVRs, but one of the things that kept coming up is, do we treat the concomitant coronary disease prior, with, or after a TAVR procedure? And we kind of extrapolate, just to say we've extrapolated from surgical data on what we should do in our particular patients, because when we get them, patients are quite elderly, and a lot of them are quite frail. But just to get started, I'll just start with this, that, okay, I'm going to now read out loud every single slide to you, word by word, until you wish you just die. But don't do that, okay? Don't do it. Don't do it. Just to give you the background, coronary disease and senile aortic stenosis, they, not often, they do coexist up to 50%. With symptomatic severe aortic stenosis, have significant coronary artery disease. And you're going to get a lesson in acronyms here as well, so I'll say it out loud, but just for slide space. And they both have common risk factors. I just put the two major risk factors, but you can also add dyslipidemia. You may even add familial or genetic. You may even add Lp(a), which we had some recent literature. Patients that have progressive senile aortic stenosis have high Lp(a) levels. We still don't know what we're going to do about it. There are some therapies we can offer, but there are fancy therapies coming down the line for Lp(a). They got a fancy name that I think they're called like a ribonuclease. I don't even know how to pronounce it, so it's going to be expensive. So, but the interesting thing about coronary disease and senile or calcific aortic valve stenosis, they actually share similar underlying pathologic mechanism, and you can go ahead and read here, but this is actually a really neat slide that if you look at the top, this is the aortic valve, and here's the artery. And you can see the slide. I know it's a little small, and sorry about that, but just getting the basic gist. This is pathology. This is the aortic valve pre-stenosis. This is probably sclerosis as it progresses to stenosis or severe stenosis. This is coronary artery disease, which is mild, as it progresses to severe or late coronary artery disease. And you can see what's very interesting is the layer of the aortic valve shares a similar endothelium as what also lines the coronary arteries. And that's why you see a similar pathway of lipoprotein influx infiltrating and destroying the endothelium and causing a cascade of inflammatory reactions that subsequently lead to narrowing of these orifices or thickening of the cell wall layer. And I keep coming back to this lipoprotein. You guys, you ladies and gentlemen, have heard of HDL, LDL, Lp(a). Well, those stand for high density lipoprotein, low density lipoprotein, lipoprotein A, and it seems to be an early mechanism of disease. And going back to that great cardiac rehab talk, and also probably also great talk by Chippy Nalluri, which I'm very eager to listen to, there are ways you can actually thwart this process for coronary disease. We're still not quite there for aortic valvular disease because we call it senile because it is a progressive disease that happens later on in life unless you have a genetic abnormality like a bicuspid aortic valve. This is a great slide. I hope you guys, any physicians or nurses or students in here, you should have this slide in your files and refer to it often. I can give it to you later. So coming back to what our talk is about is managing coronary disease in patients with valvular disease. And like I said, we've extrapolated from the surgical data. And there's been several studies. I'm just referring just probably the high yield studies. This is a guy I trained with in Boston who's now runs a Cleveland Clinic surgical program. He used to run our Marfan's clinic when I was a fellow, which is a genetic disease of the aorta and aortic valve. But what they've seen is how to manage CAD in patients undergoing SAVR, which is surgical aortic valve replacement. TAVR is transfemoral, where we don't open the chest. We actually go either through the leg or we go through the arm. And we know that untreated coronary artery disease increases the risk of perioperative myocardial infarction with both poor short and long-term outcomes. But we also know, and surgeons jump in anytime, Jeff or John, from that New York registry of over 10,000 patients, that isolated valve surgery probably portends a mortality of around 4%, but if you combine it with bypass, that goes up to about 8%. That's from the New York registry only. That was the only trial that I looked at. The numbers may be different now, but regardless, it increases your poor and short, your short and long-term outcomes. And guidelines, the ASCC, which is the American College of Cardiology, as well as the European Society, suggests complete revascularization with surgery for coronary artery stenosis of greater than 70%, and that's a level 1 indication. You remember Dr. Morsley said, there's certain things that have certain levels or classes of indication. Level 1 has pretty good data, and if there's over 50% stenosis, it's a level 2A. Which still is appropriate. Things that we don't do if they get a level 3. That means the intervention would probably harm the patient. So we're still safer. And this is this actually results in improvements in long-term outcomes with the appropriate references. There's been a talk of hybrid procedures with PCI, which stands for percutaneous coronary intervention. That's a stent. That's what I do. With or immediately preceding surgery has been shown safe, but a limited series. And this is for if you're going to go for surgical replacement of the aortic valve. It's still limited series. We're not there yet. The surgeons and I have talked about this on several occasions when we would consider this hybrid procedure, and we're still not there yet. So our goal here is to reduce a higher risk coronary artery bypass with aortic valve replacement to possibly 2 potentially lower risk procedures in high risk patients, if that makes any sense. So what we offer is PCI, which is intervention. That's stents, either through the groin, your access is through the groin or through the wrist. And we have a pretty decent trial going back to 2012 that has shown this to be safe and effective in the setting of aortic stenosis from moderate to severe. And just to briefly, what is transfemoral aortic valve replacement? Transfemoral is going through the legs, not through the chest, which results in certain morbidity in certain patients, especially high-risk patients. And we have 2 options here. And again, I'm not going to belabor this point because we did this in the last 1 or 2 summits. We have 2 options of types of valves. And literally before my talk, I actually just did a consultation for someone from Virginia who will be talking about getting his valve replaced. So we're always working. So whoever has questions afterwards, just come up and grab me. So we have 2 options. This is a device that's called a self-expanding device by a certain company where we unfurl this device, and it has this a memory. It's made out of nitinol, and it will slowly unfurl and expand to a certain size. And it has its benefits, it has its cons. This other option is called a balloon-mounted valve, which is like a stent that we use in the coronaries. And this has its pros and its cons. The big difference about from these two is one has a balloon, and one we have to pace the heart up to about 180 to 200 beats per minute. So that's essentially stopping the heart. And we do it for, I don't know, John, 10 seconds maybe? If even that? Five seconds maybe. So it's not a prolonged time of literally cardiac standstill in order to accurately place this particular valve. This unfurled valve, we tend to pace quite slower at around 100, 110, maybe 120 beats per minute. And the reason is if you look at this valve, when it starts to unfurl, it doesn't expand fast. So just think about a sail in the wind. Just think about the blood coming out of this pumping chamber is the wind, this is the sail. So we do try to decrease the amount of wind so the sail doesn't take off and end up somewhere we don't want. And the surgeons get pretty teed at us when that happens. Unfortunately, it hasn't happened. So basically the concept is trying to protect the blood flow to the heart while we're pacing at these types of, at these rates, as well as if there's any complications, do we have reserve from the coronary and hence cardiac myocardium or cardiac muscle standpoint to withstand these insults, because things do happen. I see our cath lab teams all the way up in the back, and they're not that far back because they actually aren't afraid of me, and I think they do like me, I really do. But we've seen, when we first started the program, we've seen pretty much every complication that you can have with these, because it was a learning process. So coronary artery disease. There's a greater prevalence in these TAVR patients. Like I said, these patients are older, they're a little more debilitated, and the prognostic, meaning the future risk of having coronary artery disease and implications, is actually unclear if we fix these arteries prior, with, or after these valve procedures. But we are getting some data now that's starting to help us make these decisions, which I'll show you in a little bit later. So our TAVR patients, which are our severe aortic valve stenosis patients that we're considering replacing this valve through the leg, tend to be older. I like to say more mature. Have higher comorbidity, that means other medical problems, such as bleeds history, maybe stomach ulcers, maybe strokes, maybe kidney disease, meaning the kidneys don't work as well as they used to, maybe conditions of the lung called chronic obstructive pulmonary disease, also known as COPD, maybe cancers that have a prognosis maybe of a year or two, and there's an event, you make it to your grandkids' graduation, maybe. We get a lot of reasons why people come to us. And really, it's not clear if revascularization attenuates, revascularization meaning stenting the arteries before fixing the valve, attenuates meaning reduces this risk based on some large studies, because the patients are older and have comorbidities. So the addition of coronary artery disease and fixing it maybe is not completely clear. And that leads me into, well, why do we treat this coronary artery disease in the TAVR patient? That brings me back to that, to the concept of when we have to place these valves. And when we do these valves and we pace these hearts, it actually induces lack of blood flow, also known as ischemia, and what we call heart stunning or myocardial stunning. And it's especially seen with these balloon-mounted valves due to the rapid pacing. And I have a terrible cartoon here. Let's see if it plays. And you kind of get a sense of what I mean by cardiac standstill. You see how and now watch this muscle once the balloon comes down. Let's see if I screwed that up. And then the heart's beating again. It's sideways. Sorry about that. You can watch that again. You can see what the heart does when we pace. It's completely cardiac standstill. So what that means, there's no systolic perfusion pressure, meaning the time the heart beats. There's no diastolic perfusion pressure. That means when the heart relaxes, and that's when the coronary arteries are filled. That's the primary time when the coronary arteries are filled. And so, I put this in just because I know this is tough stuff. Raise your hand if you're a nerd. That's me, I'm a nerd. All right, Jeff? Yes. When we started chemistry, we're like, yes, we're gonna blow up stuff. This is gonna be good. But it turned out it was pretty boring. Chemistry was terrible. We thought it was gonna be good, but it turned out it was pretty boring. So I'm a nerd, I admit it. So going back to the lecture. So there has been no clear consensus or agreement despite the extensive analysis of really retrospective studies, which aren't the highest quality studies. We're looking for randomized control trials. But you can just think about common sense. How are we going to randomize some of these patients? Are we not going to offer certain therapies? So we actually go back in time. And a lot of the studies don't have a clear consensus because there was not strict or coherent criteria that would define the coronary disease. And so we do have some studies coming up a couple years back that defined coronary disease only angiographically. That's from a heart catheterization. That's where we look at your arteries under x-ray after we've gone through the groin or the wrist. Some of you in this room may have had that procedure. Some of you may have had coronary bypass. Some of you may have had stents by someone like me. And in those particular patients, there was a higher perioperative risk for transfemoral aortic valve replacement. But we have to note, like I discussed a little earlier, that there was a greater prevalence, meaning these patients had kidney problems. They had leg artery problems, meaning when you walk, your legs get painful, or you've had ulcers in the legs that just won't heal. You have left ventricular dysfunction. That means your heart function is low. It's not the 50% or above that we like. So the higher risk of these patients may actually not be driven by the presence of the coronary artery disease alone. And we have some pretty big registries that try to help us move along that define coronary artery disease on angiography really did not find it to be an independent predictor of all-cause mortality. That's a big registry, but then we have another registry that shows, well, we got a little more specific on how we define this coronary disease. And right now, what we're doing is we're defining coronary disease. Now, you may not see it. The patients may not see this, but as a cardiologist and a general cardiologist, as an interventional cardiologist, we're starting to use score systems so we can all speak the same language. And that score system is the Synapt Score. Synapt Score is it's a laborious score that we all do, and MACE is major adverse cardiovascular events. That's all cardiovascular mortality, meaning you died from a heart problem, you died from a stroke, or you died from some peripheral vascular problem. And sometimes they will lump in all-cause mortality, meaning you died from something, but they will leave out if you got hit by a bus. And we noticed that if you categorize the degree of coronary artery disease and you get your score that's higher than 22, there was a higher risk of MACE in these patients undergoing transfemoral aortic valve replacement compared to those without coronary artery disease. And so we have some observational data that suggests that the severity of this coronary disease affects the risk for adverse events with this valve procedure. And so we always ask this question, given the inherent risk of doing heart cath in this particular patient population, which the risks are higher. And I'll give you an example. Let's say we have to do a heart catheterization or an angiogram on a patient that's 65 years of age or younger. The national registries would say your risk for a major cardiovascular event, death, stroke, myocardial infarction, is probably 1 in 2,000. So it's pretty low. 1 in 100 is 1%. So 1 in 2,000 is pretty low. And then other things such as kidney inflammation causing dialysis, or limb loss of either the leg or the arm, or emergent heart surgery, or other types of surgery is actually even less based on that particular age with no significant comorbid condition or medical history. But once we get a little bit older or we become a little more mature, which a lot of patients we do these valves in are 75, 80 plus. So now the risks have increased from 1 in 2,000 to about 1 in 500 to 1 in 1,000. So still, think about that for a second, it's still less than 1%, but you just went almost a standard deviation higher risk as compared to 65 and younger, which most trials, that's what most trials study. And here's a look at what we do as cardiologists to score your coronary artery disease. This is the Synapt Score. And the key is down here is, and this is in people less than 65 or less, and actually there were some 70-year-olds in there, and it's clear if you have a score greater than 22, 3-vessel disease or a severe blockage, left main is right here at number 5, coronary artery bypass is clearly the way to go if you have aortic stenosis. There's no question, there's multiple trials, there's prognostic implications, there's short, long-term implications. There's no question coronary artery bypass will portend a survival benefit, a reduced risk in myocardial infarction, there's no question. And if your score is less than 22 and you have multi-vessel disease and maybe even left main, a guy like me, interventional cardiologist, the stent is actually comparable to bypass. And there's several studies that have shown this as well. And as you can already surmise, our patients that we're going to be working on for TAVR or TAVR, they're going to be in this 22 and higher range. And as I showed on the first slide, about 50% will. And so there's our, if you look over here, there's our cumulative event rates. That's death, myocardial infarction, all-cause mortality. Here's your Synapt scores. Blue is intervention, what I do, stents. Cabbage is what surgeons do. And you can see the event rates get higher and higher with the higher Synapt score from what I do. Stays about this, maybe a little here, a little the same for bypass in these numbers if they're an appropriate patient for bypass based on surgeon's evaluation with their objective criteria called an STS score. And there's another graph about 4-year mortality. 4-year mortality, meaning your chance of dying in 4 years. As the score goes up, the chance goes up precipitously. So you may ask, well, how do you know which people to fix before, how do you know which coronary blockages to fix before you undergo transaortic valve replacement or transfemoral aortic valve replacement? Well, we have 3 different types of modalities that we can assess for the significance of coronary artery disease. First is non-invasive, the second is invasive, and the third is anatomic. And as I was telling you a little earlier, it's what we drive right now is basically anatomic, because the first 2 options, the reliability of results are a little suspect in patients with severe aortic valve stenosis. Where's Fung? Where's Dr. Fung? All due respect, he did well. And I'm a Patriots fan. That's why I put this up. Now you feel the pain, right? Because we really needed that 6th ring, that 6th trophy. We really did. We really needed it. Where's Jack? You up there? Boston. Anyone from Boston here? Yeah. That's painful, wasn't it? It was.
Sweet.
Yeah. Quiet in the front row. So non-invasive testing, that's stress test. That's treadmill. Some people in here have probably had a treadmill stress test. Some people have probably had a Lexiscan cardiolite. Some people have probably had a Persantine cardiolite, and you hated it because it made you feel terrible. Some of you had probably a treadmill echo while you're running, and the socks fall off, and they tell you, keep going, keep going. And then hurry up, don't trip, get on the table to get that ultrasound so we can get these images. And some of you have had the fancy PET scanner. You have a PET stress test. That's pretty fancy. That's kind of the gold standard now. But it's not straightforward in these patients because the stress testing is going to demonstrate lack of blood flow to areas of the heart, even the absence of severe coronary artery disease, because just think about it. You're not getting enough blood coming out through that tiny orifice of the valve. If you go back to that cartoon I showed you, the valve's thickened, valve's closed, it's tight. So when you get on a stress test, you're going to have some abnormalities. There's a whole pathophysiologic lecture on exactly what happens during this, which I don't want to bore you any more than I already am. But it's pretty complex. But what we do know is we can do this safely. There's lower sensitivity and specificity, and that means sensitivity. If it's negative, you're going to rule out disease. Specificity, if it's positive, you rule in disease. So you can just see that your sensitivity and specificity is going to be it's going to be lower to almost a standard deviation lower, and I think it's a bad test, and it's usually due to the aortic stenosis-driven lack of blood flow. And really, there's no data to support the use of non-invasive assessment to guide revascularization, meaning stent placement in patients that are going to undergo aortic valve replacement from the transfemoral approach. But it could be useful to identify hemodynamically insignificant. So if you have a completely normal stress test, you can surmise that, that some coronary lesions aren't hemodynamically significant, despite being 75% or more blocked on angiogram. Hence, you may decide not to intervene. And in certain situations, like my consultation I did just before my lecture, I told this nice man that I may put you on a treadmill to see if your symptoms are true or if it really was due to that bronchitis you recently had. But I will do it with me sitting there because even though the risks are low, remember the data Dr. Morsley showed, in people with severe aortic stenosis, those risks are a little higher. So we gauge, based on treadmill, we can gauge literally within minutes, because we do this enough, if this is valve-driven or coronary-driven. Now, invasive functional assessment means I'm doing my angiogram, I see a blockage, and I have two ways to do a stress test inside the artery. One way is with what's called fractional flow reserve, FFR, and I can already see all my cath lab techs over there rolling their eyes, or intravascular ultrasound. FFR is the gold standard, and what it is, it's a little wire I'll put through the artery, has a little pressure monitoring tip. We hook up to this fancy machine, and we infuse a medication called adenosine, and it makes you feel terrible. Makes your heart go into heart block, but we're there, so it's okay. It doesn't last long, 30 seconds. Then we always blame someone else. Yeah, I don't know what happened. It must have been the IV or something. And it's safe in people with severe aortic stenosis. It's been studied, over 1,000, 2,000 patients. It's safe to use. But the problem is you run into, again, what the non-invasive evaluation, there's significant uncertainty in interpretation with severe aortic stenosis. And here's just a brief, read these words, it's a really exercise in pathophysiology. It's actually really neat pathophysiology. And I just had a case, it was Wednesday with Dr. Ramos. I don't know if he's here. He's a cardiologist, and his team was prepping for TAVR, and he asked me to look at this patient's main artery if he thinks maybe FFR before his TAVR, and I said, well, let me look at it. I'll probably just fix it, and I'll show you why I just fixed it in a little bit. Because I know his TAVR operator, we're two different teams, his TAVR operator uses a certain valve that requires high pacing rates, and so that's why I decided to fix it. So it's nice to know your team and be a team approach. Even though we're in different groups, we actually collaborate. And so after you fix a valve by TAVR and you decide to go back and look at some blockages that you thought may be fixed, now FFR will probably be more comparable to all the data in people that, like the FAME 1 and 2, you may have heard some of those studies, in people who don't have aortic valve stenosis. And here's just a brief cartoon of some of the pathophysiologic changes of aortic stenosis and TAVR. Just the keys are, you know, when you're doing FFR in somebody in aortic stenosis, it may look normal. And then once you fix the valve, all of a sudden the FFR drops. Because what it is, it's looking at a relative pressure gradient in front of a blockage and in back of a blockage. Think about a dam, all the blood flow backing up, not getting forward. And once you open it up, the pressure, the level of water on either side equals out. So what a normal FFR should be about 0.85 to maybe 1.1, accounting for differences in the lab, fancy term called pressure drift. And you can see, and some of these other measures are very technical terms. FFR is actually a measure of coronary flow reserve, or CFR. We can't evaluate coronary flow reserve without specifically puncturing or looking inside. And I think Jeff may have done some of this work when, I don't remember if you did work like this. But you have to actually put pressure, little pressure modules and stuff inside the heart muscle to evaluate the capillary flow, because that's essentially what we're trying to preserve, is the bulk capillary flow. We fix the big canals so the sprinklers work in the fields. You can look at it that way. So really, when we identify coronary disease, it's actually anatomically, and then it's driven by other measures such as symptoms. And we look for the high SynScore score. Greater than 22 increases adverse events with transfemoral aortic valve. So coronary intervention, meaning stent placement in certain areas, may be beneficial. And the current literature suggests that we really only concentrate on severe proximal stenotic, meaning blocked, proximal meaning early, blockages with a lot of muscle at risk. And usually those are left main. Remember I said number 5 on that one cartoon and I pointed to it? That's left main. Or it's equivalent, meaning the branches are blocked. You may want to consider coronary intervention just before valve replacement, even if they don't have symptoms. And so patients with over 70% proximal or early, major, you have 3 major arteries, 4 if you count the left main, vessels, or greater than 50% vein graft, that's a bypass. Your decision for intervention is really based on symptoms, and that's the Canadian classification score of 3 to 4. I didn't put that up. I didn't put what all that means, but Canadian classification 0 and 1 means normal activities, exercise, you have no problems. 2 means maybe after some moderate physical exertion, climbing flight or 2 of stairs, or you may have some substernal chest pain or pressure. 3 and 4 are more of the unstable, where minimal exertion causes chest pain or pressure. If anyone's having that now, just let me know. That's a 4. That's a 4. You're having a 4. That's rest symptoms. And we do have a cath lab team available 7/24. I know, our humor's sick. I know. So an intervention is usually deferred with significant non-left main coronary disease, non-left main or its equivalent, with Canadian classification scores of 0 to 2. Believe it or not, how many people in their practices right now just fix them? You know, I would say that it's maybe 50-50. And a lot of this algorithm on who we treat has actually recently been published by the European Society guidelines. It's a class 2A. It's not a class 1 because there's still uncertainty. It's not a class 3, meaning causes harm. This is where we get a lot of our data, because it seems that the European is has a little bit more robust data on this, and they offer a nice algorithm that I hawked from their guidelines on who do we treat with intervention on significant coronary disease prior, with, or after TAVR based on your lab's preference. And so once the patient's considered for TAVR, your first question, is there unstable symptoms, such as unstable angina or an acute coronary syndrome? Now, technically in the past, coronary intervention in patients with severe aortic stenosis was really only reserved for people coming in hot with acute coronary syndrome, ST-elevated myocardial infarctions or non-ST-elevated myocardial infarctions to kind of cool them down. But now we're taking a little different approach, well, similar approach, I guess, but now we're taking a little different approach in folks that aren't coming in hot. And so if you have unstable symptoms and you have a yes, the heart team, which we collaborate, and now I'm looking back on that LAD I fixed on Wednesday. I'm sorry, guys, I didn't talk with the surgeons. You know, I didn't collaborate on the heart team, but I think maybe we should next time. Maybe we should stop and discuss this first, and then go from there. But considering the patient's age, comorbid condition, renal failure, STS score was greater than 10 on this particular patient, and what we know, his heart function was low. It was around 30%. What we know is those are high-risk patients, even for surgery. So knowing the data and being hit over the head with the data, with not only Synapt Score, STS Score, and a collaborative approach, we're able to make these decisions, what we say ad hoc, or right in the moment. But if you don't have unstable symptoms, everybody gets a heart catheterization, and we also do some other modalities. But everybody gets a heart catheterization, and we identify, does he or she have unobstructed, meaning no blockages? Does he or she have over 70% blockage? And just think, but remember, 70% is an eyeball thing. If you look at the intra-observer differences between this, to me, I may say it's 50%, and somebody may say 70%. Now, I told you I'm older now. I've been here 10 years, so I got to pull out my glasses now. But now I actually will go inside the artery and take area measurements, which is more accurate. And most 50% oculostenotic or eyeball, most 50%ers are actually 70% area luminal narrowing, which is significant. And so if they have that with class 3-4 symptom angina, which you now know what that is, and it's a yes, talk with the heart team, pre-TAVR intervention. If it's a no, TAVR, leave it alone. And if that's your institution's operatus, mode of operatus. If you see greater than 50% what is considered left main stenosis, all the data since the 90s, any left main that's 50% or more should be handled surgically if it's appropriate for that particular patient. A lot of our patients aren't appropriate for surgery because the mortality risks and the complication risks are just extraordinarily high that we really did them no benefit. So again, and the emphasis, I should have had this bold, is the heart team approach. That's a left main stenosis. Somebody said, yeah, go into interventional cardiology. You'll never see this. It's fun. You'll never see this. This was one of my first cases. I was like, man, it was almost as painful as this. You know, yeah, go kayaking, they said. It'll be fun. Yeah, what do you do? What do you do? Just looking like, oh my God. This dude's like, geez, that thing's huge. I like to stand-up paddleboard, but I couldn't find a stand-up paddleboard, so I crossed that out. What would you do? If you had aortic stenosis in that left main, you're shark bait, because the stress will do you. So that, I mean, what do you do? What do you do here? I mean, you know, 85-year-old patient, severe aortic stenosis with this. What do you do? 60-year-old with a great white tailing you, what do? Paddle fast. Here you have a greater than 70% blockage in the proximal portion or mid portion. It's probably mid if you want to be a technical person. It's right at a diagonal. Technically, it's over 70%. Look at all this myocardium at risk. What do? Are you going to fix that before TAVR? I think hopefully if you got what I was saying, you'd probably say yes, right? Probably wouldn't even think twice. Probably wouldn't have to talk to the heart team if you know what I mean. Here you go. Here's another maybe prox-mid lesion because you got a branch here. This is another LAD. This is a major epicardial vessel. This is greater than 70%. These are my cases. And so knowing what we know, class 4 symptoms, severe aortic stenosis, severe LAD disease. You think back, okay, Synapt Score, okay. To me, I say, well, there's a lot of myocardium. This is all heart down here, which you don't see. This is all myocardium at risk. So we fix it and we lost our branch, but it'll come back. We lost our branch. Tried to get it. Remember that one, Tim? I don't know if you remember that one. Tried to get it, couldn't get it, but it came back. The branches always come back. Unfortunately, we call them the daughters. We got to take care of mom first, not the daughters. It's that vessel again, that's us fixing it. Here's another proximal, maybe mid, technical, but it's pretty high up. This is the diag. Technically, if you talk to Dr. Grossman or Boehm, king of interventional cardiology, they'd probably say mid, but to me it's proximal despite it being just after the diagonal branch. Another LAD, a lot of myocardium. Would you fix that before TAVR? Class 3 symptoms. All right, here's the question, class 2 symptoms. Would you fix that before TAVR? Class 2, depending on what you're comfortable with. You know what I would do? I would probably do an IVUS. I would even, despite knowing the uncertainty of FFR or something, I would probably do something else to support my decision to fix this despite not class 3, 4 symptoms. We fix it, looks good. Here's a right coronary artery, really banged up from here to here to here. So it's supplying the entire bottom part of the heart, maybe the right ventricle, depending on what kind of valve we're going to use. Are we going to fix this beforehand? This person is going to go into heart block. What kind of valve are we going to use? What valve causes heart block more than the other? So these are the types of questions we're going to ask. Here's a good one. Here's LAD, here's a ramus, here's a circumflex. Maybe 70%, mid-distal. Here's the question. Who would fix this one before TAVR? Nah, I didn't fix this one. I left this one alone, and they did fine. So you can see that one cartoon kind of helps you, class maybe 2, 3 symptoms in between because of the aortic stenosis. I left this one alone. And you can see not a lot of territory. You have this ramus that parallels the artery, so meaning its tributaries or sprinklers. This is the canal. These are the sprinklers going to the field. You can see it parallels this area. This area is probably going what we call the AV groove. It's a little scar. There's no muscle there. Who cares? If you're going to have a heart attack, this is the one to have. This is a wimpy one. This is a wimpy heart attack. Who cares about that one? Okay, this is the 1, 2, 3. Aww. That's monkey, that's bear. Those are my dogs. Good looking dogs, huh? So, and some people say, well, when do you do interventions before the TAVR? I mean, our institution, we tend to do them before. Here, that's staged, combined, TAVR alone, pending the anatomy, like I showed you. Staged is blue, pretty safe. We tend to do maybe at least a couple weeks before, lower contrast. It has its pros and cons. Maybe there's a complication during the intervention because these folks are more mature, which will delay the TAVR a little longer maybe. I mean, we've had to do emergent TAVRs, but we tend to try to do balloon valvuloplasties first. We've had several emergent ones. We've had people come in. We had a recent one, I forget if it was Jeff and me or John and me, but we had a recent one that we had to do a valve-in-valve, and he had infected gallbladder, so he survived that insult. Luckily, he was only 60, so he was pretty young. So he had to undergo, we had to get him through abdominal surgery before we can fix the valve. Now think about that. We get him through abdominal surgery of an infected gallbladder with severe fake valve stenosis, and he did fine. And then we fixed his valve, and he did fine. So our institution tends to do staged. Concomitant, I think, or combined PCI and TAVR, I think makes the procedure longer than it should be, unless you absolutely have to, like, you get in there and you notice the leaflets of the valve are long, and they may occlude either the orifices of the coronaries, and so now you have to protect them. So we've done that. We've had to go through the radial, get a guide up, put wires down the coronaries, put stents about midway down the coronary before we put the valve. Everything's waiting. Then we put the valve in and deploy it, take that out, and now pull the stents back to reopen the openings of the coronaries. That's what we call you lose interventional sweat on. That's when you take off your lead and you're just drenched in sweat. It's a great way to lose like 3 pounds.